Hello, everyone. Dr. Perkins here with the Be Better podcast. Thank you so much for joining me today. Today's episode is called Be Better with Physician Dr. Michael Givens. What is Be Better podcasting? Be Better podcasting shares information from fascinating people all the way to pop culture. You are encouraged to glean from this content to go out there and be better in the world. It's as simple as that. All right, Dr. Givens, thank you so much for joining me tonight. How are you feeling?
I'm doing good. It's a pleasure to be here with you.
All right. Thank you so much for your time and effort in this endeavor. Thank you so much. Let's start with the questions to give the people a little background about yourself. Please tell us, how did you get started as far as going from a little kid all the way up to high school to college and then getting into the doctor thing?
Yeah. So I'm a physician. I work in private practice. My focus is on interventional spine and sports medicine. I got into medicine. I was interested in medicine pretty early. What drew me to the field was my mother. She was in and out of the hospital growing up, and kind of seeing her have different doctors treat her and going through what she was going through, I always wanted to have more information. I wanted to be able to kind of figure out and explain what was going on. And also, I saw some of the people that were caring for her and realized how much of an impact that they had on her life and also kind of my life going through that process. So that was what initially drew me into wanting to go into medicine. And I would say pretty early on, probably going stemming back to like fifth or sixth grade, I was one of those kids that was wanted to be a doctor, kind of going into school. As far as kind of the process of kind of getting into the field of medicine, um, it started. I went to undergrad. I went to Duke University, and there you don't really learn about medicine in undergrad. What you learn is kind of how to prepare to train for medicine when you get to med school. So you have all your prerequisites and those courses that are really teaching you how to study and digest all the information, but you're really not learning anything about medicine. Now, after undergrad, you apply to med school and you have to take the MCAT. That's the standardized test that helps when you're applying to med school. For medical school, I went to UCLA, the David Geffen School of Medicine in Los Angeles. And I actually graduated from med school in 2012. And med school is where you really start to get into the meat of kind of digesting all the information. Some people describe it as trying to drink out of a fire hydrant. Like you're just getting all this information thrown at you, and it's truly broad because you're really trying to figure out what field you want to go into. So the things that helped me get through med school were everything that I had done before, from high school to undergrad, kind of learning how to study, learning how to take tests, and kind of get the most out of the information. All that is what helped prepare me for med school and make sure that I wasn't overwhelmed when I got to that process. Now,
Very, go ahead. Go ahead.
Now, the first 2 years of medical school are strictly books. So you're not seeing really any patients. It's really just like you're learning all the things in the book. Your third year is when you start getting into the clinical. So you kind of put the books down and you get into the hospitals and the clinics. You're seeing patients, you're shadowing other doctors, kind of learning those clinical skills. And then your fourth year of med school is where you you start to kind of branch out and do your electives. You start saying, do I want to do surgery? Do I want to do internal medicine, radiology? You start doing those electives and start finding out what path you want to go down within medicine.
Now, can I interrupt you really quick? During
Yes.
those couple phases right there, those years, are you getting paid?
So med school, you are not getting paid. You're paying to go to med school those first 2 years, and even those clinical years, you're still paying. You don't start getting paid until you get to residency. So
Okay,
it's
very good. And
really
I wanted the audience to understand that. So good, very
yeah,
good.
and it's a huge commitment. Anytime you're going into medicine, you're deferring making income for a lot longer than maybe some of your colleagues. I remember I had friends when I was in college, going into med school, they're starting jobs as a firefighter, and they start making money. They're buying houses, and all that for you is deferred as you're still in school. You're paying to go to school, and once we get to the residency part, I can go over kind of the income that you are making, and it's pretty much minimum wage when you're in residency.
So it's a commitment of like you just said, your friends are graduating, and they're getting their cars, their house, their boyfriend, their girlfriends, or their future husbands, or their future wives, and you're still in school.
Yeah, I had
So it's a
friends.
commitment of deferring that and saying, okay, that's good for them. I
Mhm.
wish them well, but I have this commitment. And at the end, my results, as far as probably salary and other things, will be bigger.
And I think it is important for people wanting to go into medicine, kind of realizing that it's that deferred kind of, you're getting kind of a later start. And you see a lot of people. There were some people in med school that they had already went to business school and started working, or they were doing law and working, and then they realized they want to go to medicine and then come back to medicine. Versus in my case, it was mostly I went from high school, undergrad, and then to med school, and not really making income. You do side jobs like during the summer, but you're not truly making income during that time. So after med school, once you graduate, there's actually and you apply to go into residency. For myself, it was going into physical medicine and rehabilitation was the field that I chose. And the reason I chose that field is I was really interested in sports medicine, potentially doing procedures, and that was a field that offered that, but also other things that I was looking for, which was kind of having a balance between kind of medicine and a personal life. Um, so once you decide what field you want to go to into in medicine, you have to do a match. It's a process where you apply to the residency programs that you want to go to, and you interview, and they have a list of their top choices as far as their candidates, and then you also have a list of the top programs that you want to go to. And it's a match because as they go down their list and you go down your list, you end up matching. So some people get their first choice, some people get their second choice, some people get their third choice. So my choice was to go to UCLA and stay in UCLA for residency, and I was fortunate enough to stay and go to their program. Now, before I started residency, you actually have to do a preliminary year. So I didn't start right into physical medicine and rehab. I had to do a year of just general training, and I had an option of doing general surgery or internal medicine. I chose general surgery as my introductory year, and I actually came back to Phoenix, Arizona, and did that at St. Joe's Hospital and Medical Center. And the reason I chose general surgery, it was two reasons. One is I knew I was going to get to use my hands, and that was something that could benefit me going into my field of interventional spine and also sports medicine. In surgery, you're in the operating room, you're learning how to stitch. So you were getting to kind of train and use those skills. The other reason I chose surgery is I, in my head, said this will probably be the hardest I'll ever work in medicine. And if I could do this, then I'll be able to do anything in the rest of my career. Because surgery, you wake up early, you work long hours, you're on call, and it's just kind of nonstop. So that year, I was really busy. I was actually started making money that year. That was once you start getting this, uh, but I was probably working maybe like 80 hours per week.
Wow.
Sometimes more. You would work basically. I was on for 12 days, and then I would get 2 days off, and then you were on for 12 days and then 2 days off. So
Wow. Were
it
you
was pretty.
sleeping during those 2 days? Off?
You sleep, and it's tough, and like I said, during residency, that's what you hear. People prepare you like you're going to get to residency, you're going to work hard, and it's really you work hard, but you're really learning so much during that time because it's all hands on. You're learning from your attendings, and you can't replace that time. So you have to look at it like that. Like this commitment that you're putting in is really honing your skills for the future. So I I enjoyed my time after the year. I was like, I enjoy doing it, but I'm happy I'm not doing it anymore. But it really was something where you can't replace that experience. I saw so many things that I still refer to, even though I don't do surgery now. When I do talk to patients about a surgery that they might have had or recovering, I can take some of that knowledge that I learned that year and apply it still to some of the patients that I see.
So that on-the-job training is very, very valuable.
It's valuable. And if you're not in the hospital, like you can read books but it's not the same experience as being in the hospital and seeing it and going through it. So it's a crazy year, that intern year, but it's something where it's invaluable as far as for the rest of your career. Now, touching back on the pay, I think I was making probably like 50,000 a year, which is good when you weren't making anything before. But then when you think that you're working 80 hours a week, you start breaking it down. You're like, you're not making that much. But
Right.
but you're also you're getting your education. You have to think of it as you're still in training. Instead of you paying for your education, you're getting paid, but you're truly still getting educated during that period.
Gotcha.
Okay. So after I finished my prelim year of general surgery, I went back to LA and started my residency. So you can look at my residency as fully being 4 years total, with one being that general surgery prelim year, and then 3 years of residency in physical medicine and rehabilitation. And in this, it's once again kind of like being in med school. Like you're really learning your specialty, a bunch of new information. Within your specialty, there's different avenues you can go down and specialize within that. So you're trying to figure out, do you want to just do general physical medicine and rehabilitation? Do you want to specialize and do spinal cord injury? Do you want to do interventional spine, interventional pain management? So it is like kind of being in med school again, but you're getting that clinical experience and you're also getting paid once again. Still around like 50,000 each year. You get a little raise, and I didn't work as many hours as I did during my first year. As far as when I did general surgery, I was probably doing like more like 40 to maybe 50 hours.
Okay. Now
And
the math is getting a little bit better.
yep,
Okay.
getting a little bit better. And you'll see this as you kind of go through medicine, as you kind of age through the process, things start to get better for you. But what I will say is the reason I chose this specialty is because I really like the balance between kind of your social life and kind of your career. So I wasn't in the hospital for 80 hours a week and working 12 days in a row. I had pretty much an 8 to 5 kind of gig, weekends off. When I did take call, because I was taking care of patients at the hospital, I got to take call from home. So if there was an issue, the nurses could call me on my phone. And if it was something I needed to come in for, I would drive into the hospital and see the patient. But most of the time, it wasn't an emergency. It was a simple question where I could answer, put in the order over the phone. So that was that balance where some of my colleagues, they were pretty much still doing that 60 to 80 hours a week. I was kind of able to kind of have a better balance between my career and kind of family and my personal life. So after I finished my residency, so that was kind of 4 years after med school, and that was back in 2016. So I was 31 at that time. I was trying to make the decision what I'm going to do next. Am I going to go into just general physical medicine or rehabilitation, or do I want to become even more specialized and do a fellowship? And I made the decision to do a fellowship in interventional spine and pain management. And I was fortunate enough to also be able to stay at UCLA again for an extra year and do that at the UCLA Comprehensive Spine Center. And during that year, it was pretty much just honing my skills on doing injections for the joints, shoulders, hips, knees, ankles, injections for the spine and treatments for the spine. So treating neck, low back,
Can I interrupt you real
Mhm.
quick because this has sparked a major question that just
Yeah,
popped into my head. The NFL. Do you know this? And what can you share about this? Do they really go into when they're kind of quasi injured, go into the locker room, and the myth is they get a little shot and they come back out and play? Is that true or false?
it's probably true. So maybe you're having pain. You might get a Toradol injection, which is just an injection to the muscle. It's a potent anti-inflammatory, and it might help with some of your pain. Same thing with getting like a steroid injection. Say you aggravate your shoulder, they might examine you, make sure like nothing mechanically seems really off, but they might inject your shoulder, a little bit of medication, kind of help you play through the injury.
Now, will it last kind of for the duration of the game, and then at the end of the game, or maybe the next day, will you feel things, the pain?
Yeah, so what you're likely getting relief from is the numbing medication, the local anesthetic that we inject. That will typically last for about 4 to 6 hours.
Okay.
So that gets you through the game. Also, we inject some anti-inflammatory medication, but I always tell patients that doesn't kick in right away. That usually kicks in a few days. So that might help their pain kind of over the next week and kind of keep the inflammation down in the joint. But I definitely see that as being something that they do kind of
You
get you
hear
through this
inklings
game.
of that, and I was wondering, is this really true? And you kind of believe it is because you hear NFL athletes kind of
Yeah.
quietly say wink, wink, yes, but they don't come out and say it out loud.
Yeah. And I'll tell you, the danger of that is your body, when you're having pain or you're experiencing pain, it's kind of your body signaling to you that, there's something going on. You need to take it easy. If we come in and shoot you up and then send you back into the game, your body's not going to be able to give you that response. If something really isn't feeling good, we
Ah,
block that.
that's the
So
danger of it. Yep.
it can lead to you actually injuring, say, your shoulder or your knee even more because you're playing through the pain that you can't feel.
Gotcha.
So,
That's the possible consequence.
exactly.
Okay, very good. All right, I branched off into let's bring it back. Okay.
Yeah. So that year of kind of doing my fellowship, it honestly was probably the best decision I made in medicine because you think, man, I'm 31, another year of kind of delaying, kind of making what you would say physician or doctor money in order to do another year of training, and it's something where a lot of people might say, no, I'm just going to start working, start making money. But in my case, deferring in that year opened up so many more opportunities for me because now you have a set of skills that other people don't have. And so
There you go.
now
So
when I go,
sacrificing and not being in a hurry, there's rewards.
yeah, and if you look at it, so I started my undergrad. I graduated from Duke in 2007. I graduated fellowship in 2017. So that's 10 years of investment throughout your career. And if you look at being done in 9 years versus 10 years, is it really much of a difference, especially when you think about all the opportunities that it's going to open up for you?
Very good. Very good.
So that year of training, I probably did over like 1,200 procedures. And it really taught me how my attending and fellowship always told me when you're done, I want it to be so that if I wake you up in the middle of the night out of kind of a deep sleep and say you need to do this injection, you don't have to think about it. And that's how I felt once I graduated. When I started, I was nervous with everything I did. You're like you're injecting people's spine, and but the nice thing, and I'll say throughout my whole academic career, I've been very fortunate, whether it was at Duke, UCLA. I had instructors and teachers that really were invested and really made the experience enjoyable. I never felt like this is a horrible, like and med school is always like pimped or they're trying to make you look bad. I always felt supported and people had my best interest. So at the beginning of fellowship, they're holding your hand. They're right behind you. They're correcting you. Nothing where it's like you're doing it wrong. They understand that you're learning and you're going to get better as you go along. But I would say about halfway through the fellowship, my attending took the reins off and he would just kind of sit in the corner and watch us. And we were basically kind of doing the procedures. And that's where by the time I was out, I was confident that no matter where I went, I was going to be able to do kind of the procedures I had been trained to do. So,
Awesome, awesome. So what I'm
mhm.
hearing is, from all the years you just mentioned, was this a 10-year commitment or even longer?
So from basically undergrad to the end of fellowship, it was 10 years.
10
So
years.
I basically was on my own at the age of 32. And that's when I took my first job out of fellowship. I had moved back to Arizona and joined a private practice doing interventional spine.
Awesome, awesome. So I heard a lot of commitment, the discipline to succeed, the discipline to be patient while your friends and maybe family, they're graduating, they're going on again, buying the cars, the houses, getting the
Mhm.
guys, the girls. You're still in school and putting in those hours, not getting paid to getting a little bit of pay. And then at the end of the rainbow, boom, there's the payday. Not only that,
Yeah,
you have the experience and you're ready to go.
exactly. And I would say and as I was coming up, it was like social media was getting like bigger and bigger, the face. So it's always you log on the app and you see like, oh, they're out. So you have to kind of mentally be able to kind of shut that off and say, I can't be jealous of what someone else. I got to focus on what I want to accomplish. And you always have your goals in front of you. And it might take you a while to get there, but as long as you see that you're making progress to that goal, that's what keeps you going. So,
Awesome, awesome. That's a really good story. Again, all of that drive, that will, that commitment to make it happen. Very
mhm.
good. Thank you for sharing that.
Oh,
Did I
no
miss
problem.
anything before we transition?
No, I think that's pretty much
Okay,
like the journey kind of captured everything.
very good. Let's transition into patient care. That is a big deal. What advice would you leave with the audience about what they should know about patient care and the questions they should be asking?
Yeah. So with patient care, and for me as a physician, it's probably one of the most important things about being a physician. Our goal is to have good outcomes, improve the patients not only in my field, like pain and also their functional activity level. But I also want patients to be satisfied with their care. The one thing I would tell patients is there's no stupid question. The goal should be when you see a physician and you leave that physician's office, you kind of understand what the treatment plan is and why you're getting that treatment done. Especially when I'm doing injections on a patient, injections near their spine or whether it's into their knee or their shoulder. I want the patient to know why we're doing this injection, what the benefit of doing the injection is, what the risk of doing the injection is. I think when I see patients and they come in and they don't even know what procedure they're having done, I think it's sometimes it might be that the patient really isn't interested in knowing those details, but I think a lot of times it's as a healthcare provider, it's us not giving those details, just saying this is what we're going to do, maybe giving the patient a handout and they're out the door. So I think it's important for patients to kind of ask questions and really understand the treatment that we're doing. And I honestly, as a physician, think that it makes the patient's experience better. I think the biggest compliment I get is when patients say, like, I've never had a doctor explain that to me like you have. So that's what I want all my patients to leave telling me, saying, like, you took the time and explained it better than anyone's ever explained it to me. So,
And that's great advice right there for all the audience out there. Remember those words that when you go to visit a doctor, you should leave that visit feeling good that I know what's happening to me and why. So please,
exactly.
audience, ask those questions. Do not hesitate or be intimidated by your doctor. It should be a relationship, correct?
Exactly. That's it. It is a relationship, and I mean, it sounds cliche, but I treat every patient like I would treat a family member. So it doesn't matter where, if I'm training in the boonies in the middle of nowhere, or if I'm training in kind of the wealthiest place in the country, every patient getting the same standard of care. So.
Awesome. Very good advice to share. Thank you. Now, you have mentioned areas that you specialized in sports medicine, spinal care,
Mhm.
and some pain management. If someone came in to see you for a sports injury, what would be kind of a routine? Would there be a series of visits? How would you get them through all the way to healing?
Yeah. So typically, when a patient comes in, we'll do a consultation, and usually it's like a 30-minute visit where we kind of review their history, kind of when did their pain start, what's their pain like, what's their limitations due to their pain, and what things have they tried. The what things have they tried is very important because typically when patients come to me, I usually look at whether it's a spinal pain, whether it's musculoskeletal like shoulder, knee, hip. There's usually kind of a standard that you kind of go through as far as care. So typically doing physical therapy, rehabilitative therapy, chiropractic care, those are usually like the first step of care. And typically if patients have gotten to me and they haven't done any of that, that's usually the first thing that we're doing. Because some patients get better with conservative care, and conservative care has the least amount of risk associated with it. So if a patient has already done that, then they come to me, then we start addressing kind of injection treatment options that we can do. And usually patients, when we're getting to that point, they've had imaging done, whether it's x-rays or an MRI of the area, so I can go over the pathology, what injury that they have. And even once I do my injection, and I tell patients, even if you get 100% pain relief, I still want you doing physical therapy and rehab therapy, because my injections, I tell patients, will get you through that acute pain, that acute injury. But the goal is to strengthen up the area. So say if you have a shoulder injury, we want to strengthen those upper back and those periscapular muscles around the shoulder so that even once my medication wears off, that your pain doesn't come back because your body is in a better position. Now, every patient that comes to me doesn't get better. There are some patients where, say, you have knee pain and the patient has bone on bone arthritis. I might offer injections to try to prevent them from having surgery, but some patients, the pathology is just so severe that they need surgery. So that's that third tier of treatment where if a patient comes to me, and our goal is to prevent them from having surgery, but sometimes patients' surgery is the treatment that they need. That's kind of the next step where they've done therapy, we've done the injections, surgery is kind of the thing that we refer them out. I don't do the surgery. I typically will refer out to a neurosurgeon or orthopedic surgeon for that.
Very good. So acute meaning short term, chronic meaning long term.
Exactly.
Chronic
And
over a year.
chronic is typically over a year. Acute is typically uh, acute is just acute, but usually you're looking at a year for chronic pain.
Okay.
I do have chronic pain patients. I don't do any like medication management, but there are patients where they don't want to have surgery, and the injections we do give them like 4 to 6 months of relief. So we might see them a couple times a year to do the injections that keep them active and functional. Uh, and I see all populations. So I see young patients who maybe injure themselves playing tennis or basketball, versus I see elderly patients where they have more degenerative disease. So it's the whole spectrum that I see. But ultimately, for all patients, the goal is to get them functionally active again. That's the goal.
Very good. And you use the terminology pathology. The pathology is so bad. What does that mean?
So when we say pathology, it's usually trying to describe what's the reason you have the pain. So we'll use the knee for example. So if a patient comes in and they have bone on bone, you take an x-ray and there's no space in their knee, it's bone on bone. The pathology is they have severe osteoarthritis. Versus a younger patient that comes in, they maybe were playing soccer and pivoted wrong and they've been having swelling and pain in the knee, they might have a meniscal injury, a tear in the cartilage in their knee. And that would be the pathology. Their pathology is a meniscal injury.
Let's while we're on this topic, I used to be an avid jogger.
Yeah.
Now I can no longer jog because my knees hurt.
Mm-hmm.
So what would that mean? Is there something in between? Is there a cartilage or something in between that has gone away because of my age?
Yeah. So what happens within the knee joint, you typically have that compartment. You have space. If you're, say, 18, you take a picture of your knee, you're going to have a nice big space in that joint. And that space is where the cartilage is. And that way, when you're running, you have that cartilage that is cushioning between the bones. As we age, and I tell patients, everyone gets arthritis. Now, you develop arthritis faster if you're an active person. So we were talking about the athletes that kind of, you see athletes, I think I heard Dirk Nowitzki, there was a quote from him last week where he said he wished he were to retire 2 years earlier, he wouldn't be walking with a limp. So
Ah,
when you push your body, that arthritis is going to develop a lot quicker. So in your case, for example, the pain that you're experiencing when you jog is probably from degenerative arthritis in your knees. So that cartilage between the joint has worn down. So one treatment. Oh, go
can I get a surgery? And I've heard that older people around my
ahead.
age get surgeries and they're regenerate. They're refreshed
Yeah.
and they can jog again. Is that true? Or
So there's a lot of different treatment options. Kind of going back to what we talked about, surgery is kind of that last resort
okay,
because surgery has the most risk. Now, like I said, surgery has its place for people that have failed everything before. But in your case, you're looking at physical therapy. So sometimes strengthening those structures around the knee, kind of above and below, can help ease some of that knee pain. Injections, you can do anti-inflammatory injections into the knee. Typically, will give you 3 to 4 months, but can kind of ease the pain, keep
okay,
you active. Like I said, the goal is to keep you active. We might say the pain will never go away, but if you can get 3 or 4 months of relief, and you're like, I can do things that I enjoy doing, like jogging and running, then some patients opt for that. There's also gel injections that you can do into the knees that add some cushioning, act like a lubricating solution in the knee joints. And there's also kind of the new regenerative things that are coming out today, the stem cells and the PRP that a lot of people are excited about.
okay, very good. Let's transition over to the investigative medicine, such as, like you said, stem cells and the PRP, which is, I'm reading from my notes, platelet-rich plasma. Can you tell us about that? Because that's kind of new, it's uncertain, it's different, and people are skeptical.
Exactly. So both PRP, which is like you said, platelet-rich plasma therapy, and stem cells fall under the category of regenerative medicine. And typically, what regenerative medicine, what we're trying to do is we're trying to promote healing, repair in your body. Okay, with stem cells, we're injecting cells that we think can become functional tissue and kind of replace the damaged tissue that say is in your knee, like we were talking about. With PRP or platelet-rich plasma therapy, we're trying to promote a regenerative process within your body to try to heal that underlying arthritis or that cartilage injury in your knee. Okay. Um, I was kind of looking back. I did a presentation on regenerative medicine when I was in med school. So I was looking back through some of my notes, and it's been around for a while. Like athletes, I mean, Kobe Bryant, 2011, got PRP in his knees. Peyton Manning, before he had his neck fusion back in 2011, got stem cells in his neck. So it's been around for a while, but over the past few years, it's been kind of more, you're seeing kind of a, a person like you, not an athlete. Before it was all athletes that were getting this. They would go overseas, get these investigational treatments. Now we're seeing patients my age, patients your age coming in saying, hey, doc, what do you think about these stem cells or PRP? Now, the one thing I tell patients about these treatments is that they are truly investigational. And in medicine, we always like to practice evidence-based medicine. I love being able to tell my patient that when I inject this steroid in your knee, it's been tested. Large studies have shown that 80% of people get better from this treatment, and there's very minimal risks from the injection. With stem cells and PRP, I can't tell patients that. It truly is. There's a lot of case reports and small studies, but there hasn't been a landmark study to kind of show that this is the definitive treatment for treating osteoarthritic knee pain or a tear in your knee. Now, and that's also the reason why insurances don't cover these
Mm,
procedures. It's truly investigational, and it's truly it's cash pay. I've had patients, I mean, not for me, but tell me that they paid $10,000 to get stem cell
wow.
injections in their spine or in their knee. So it's something where I always caution, and it's kind of going back to when we talked about patients, what is it important for you to do? To ask questions. If you're interested in getting stem cells or PRP, ask questions. Where are the stem cells coming from? What are kind of the results that you typically get? There's so much unknown about these treatments that kind of my concern is that it's easy to get patients excited about this, but are we truly giving them the outcomes that they're looking for, especially when they're paying so much to get these
Right.
treatments? Because in the end, it's all about patient care. But there is also the business side of medicine. And I don't like when the two kind of get mixed. So when someone's paying so much out of pocket, I think it's important to really let patients know that, this is an investigational treatment. Make sure that they failed everything else, maybe stuff that's been covered by their insurance. And if it's really kind of a last resort, maybe you go down that pathway. Now, me personally, I have done a lot of PRP, platelet-rich plasma therapy, and I like that treatment for myself. Is I know exactly where the product's coming from. We're drawing the patient's blood, we're spinning it down in a special machine that will separate the layers of the blood and extracting the platelets. And then we'll inject those platelets, say, going back to your knee, inject those platelets in your knee. That's going to produce an inflammatory response to bring in those healing cells to help repair and create a regenerative process in that joint. And I know when I inject your blood back into you, you're not going to have a bad response. Your blood's been flowing through you this whole time. So that's the treatment that I've kind of honed in on for doing for my patients. And honestly, my patients get good results from it. So like I said, I still tell them it's investigational. There's no landmark study that I can give you and say, but I haven't had patients have complications, and I had patients have good results. And hopefully in the next few years, we will get those studies that start showing like PRP gives you better results than a steroid injection or a gel injection for your knee. And then we'll start seeing it covered by insurances, and you'll start seeing it more mainstream.
Very good. Thank you for that advice with the investigative medicines. A lot of people want to know a little bit more about that. So, very good. Thank you for sharing. What is your future plans in medicine?
I mean, I'm still early in my career. This is going to be going on my 5th year in private practice. I would say in the future, I would probably want to get. I'm not big on like academic medicine, but I wouldn't mind doing some teaching in medicine, as far as like my fellowship director kind of having me under his wing and kind of training me on doing the procedures. Doing something like that down the road, it could be my way to kind of give back to medicine and kind of training the new generation. So that could be something I see in the future. But right now, it's more just been kind of continuing to learn, because the one thing about medicine that is I think is really cool is the learning never stops, because there's always new technology, new treatment. So you're always having to learn and stay on top of those things, so you don't fall behind.
Very good. I love that giving back, service to others approach, attitude. And I encourage
Exactly. Yeah.
the audience, whatever you're doing in life, always please think about giving back to others. In other words, especially that generation below us that are younger, reaching back and pulling them up. So very good. I love hearing that.
Yeah.
What was
And
your
the one thing
experience? Go ahead.
I was gonna say, the one thing I would say is it's not even like I'm thankful not even for the people that taught me, but the patients that allowed me, like coming in as a resident and doing a knee injection. The patient has to say like, yeah, I'm comfortable with him doing the injection. If the patient doesn't allow you, like you don't get that hands-on training. So that's the other thing I'm thankful for, and that's why I would say I want to get back in medicine, because I wouldn't have got here unless people kind of contributed their time or their body to help me kind of get the skills that I have today. So,
Wow, big words, contribute their body. I like that. Very good. What would your experienced self say to your younger self if you could go back in time?
I I was gonna say pay on your student loans while you're training, but I would say that kind of, and we kind of touched on it, like don't rush things. There's always times, like you said, you see your colleagues or you see your friends and you kind of get jealous and you're like, I wish I was able to do that. And I would just kind of be in my ear saying like, it's going to pay off. Just keep your head kind of focused. Also enjoy the experience. I I loved the institutions I was able to train at, and the people that I met along the way. Like those people really shaped kind of the person I am today. And I going back to college, like initially I thought I was just going to stay in Arizona. Like I'm going to go to Arizona State University, University of Arizona. And the best decision I made was to kind of just branch out and try something new, because the people that I met from all different backgrounds, like those are the people that kind of taught me and helped me get to where I was today. So that's the other thing I would tell a younger self. Like sometimes you have to take those risks in order to get the most out of life. So don't shy away from those risks.
Taking risk and don't shy away. Awesome. What are the rewards and challenges in the medical field?
So the rewards is, and I always say sometimes in medicine, you don't always get the praise for your hard work. A lot of times you hear more about the complaints, the patient that maybe had like a bad experience. You don't hear you hear the one patient out of the 50 that had a bad experience, but you don't hear the 49 patients that are like, wow, your treatment was amazing. So I think, and the one thing my attending told me in fellowship is the patients that are doing well, you're not going to hear from them. They're moving on with their life. And that's the goal. Our goal in medicine is to treat the patient. We want them to get back and enjoy their life. So I tell the patients, if I don't see you, I love taking care of you, but if I don't see you, that's a good sign, because that means you don't need me. You're doing well. So I think the reward is when patients do get improvement and they are thankful. The challenges is, and for me, I'm a perfectionist. So if I do something, I want it to be 100% perfect. So when you do have that one patient that had a bad experience, it's something where you will kind of analyze everything and figure out what you could have done different. But then you have to realize that you can't please everyone, and all you can do is just bring your best to every situation. And like I said, sometimes it's patients have that bad experience, but it's not a knock against you as long as you're giving your 100%, like with everything that you do. So
Very good words. I would encourage the audience, as a step of being better, to reach out every once in a while. It doesn't have to be an everyday thing, and thank a doctor, thank a teacher, thank people for their service. So very good. I think we missed that. Like you said, we only complain a little bit more versus gratitude. So
yeah, and it those little I had an experience where a patient was having a bad day, and we made a decision was for best for his medical care that he didn't agree with, and he was pretty upset. And the one thing he did when he came in the following week is he apologized, because he realized, he said, what you guys did was actually the best thing for me. And he was like, the way I reacted, I feel horrible. And I told him, like, we don't hear that a lot. Like, I appreciate you. And it wasn't even directed at me, it was another staff member. But I told him, like, I really appreciate it, because we don't hear that. We'll get chewed out, and then patients later on will say, like, maybe I was a little bit too rough on. But honestly, as a medical provider, we just want the best for our patients. Like, we want to keep you safe. So patients might not agree with decisions that we make, but honestly, we have kind of your best intentions at heart. So
just that little piece of gratitude goes 100 miles for the other person on the other end. So
Mhm.
very good advice. How do you balance your career and your family life? You have a little one and a
Yeah.
wife. And so how do you balance all that?
I think, and it goes back to when we look at kind of, you put 10 years into this career and you kind of put a lot of things on the back burner. But I think the one thing you can't put on the back burner is your family. Like you really have to have that balance. When I had my son, or my wife had her son 2 years ago, it really made me kind of change and say, I don't want to be the dad that brings home work and is working basically from the morning all the way to the night and not having time to put my son to bed or read a book to my son. So I kind of made a change in my career to have more of a balance, and it's actually worked out for the best. I've decided to have more control over my schedule, and really try not to bring home work if I don't have to. That way, I keep work with work, and when I come home, I'm just a dad. Now, if there's an emergency or I'm always there to turn on that work side. But I think it's important to have that balance because you'll get burnt out. The first couple of years of my career, I started to feel that burnout where it was just like a vicious cycle, and you start to lose that enjoyment. And you go into medicine to help people, and so that's what you have to have that balance. I think that balance is going to make you a better doctor. You also have to realize that sometimes your time is worth more than money. Like, you can work crazy and make more money, but is that going to make you happier? For some people, it might. For me, I'm happier when I can spend more time with my family, my wife and my son, visit my parents more. So that's all. Sometimes I say, time is more valuable than money for me. And then also, just your future is not promised, like your future, your family members. So you have to also factor that, like, I want to enjoy the time with the people while they're there, because once they're gone, like, you can't get that time back. So those are all the things that made me kind of say I have to have that balance between my career and my family life. And that's honestly the reason why I chose this career, because as I was going through school, I realized if I go down this path, I can potentially have that balance. Versus if I went into surgery, it's impossible to have that balance. Like, you have to be in the OR operating on people to keep those skills up. So, like I said, I'm very happy with kind of the balance that I have. And some people don't get it as early as I've gotten in my career. They find out sometimes when it's too late, when they've been working like 15, 20 years. But I've been fortunate enough to be, like I said, 4 or 5 years out, and I've already found that nice balance. So,
Very good to hear. Some people want to chase that career, that money, and then they get, like you just said, 10, 15 years in, and what do they have to show for it?
yeah,
They have the money and career. But where's the family at? So I use the
exactly.
analogy of an airplane wings where they're chasing money, career, and it's like this, and your family life is going down. Now think of this as an airplane wing, and where's the plane going? Right to the ground.
Exactly. Yeah.
And so you got to find out, you got to keep that balance and keep that plane, that family moving forward. So
hmm
very good advice. Thank you for sharing. Any final advice, thoughts for the audience?
I think my advice for, especially if you're younger, say you're younger, you're interested in getting into medicine, don't don't kind of handicap. I don't even know if that's a good right. Always think big, because one thing that probably could have changed my trajectory is sometimes I underestimated myself. I was like, oh, I'm not going to get into that school, or why should I apply to that school? Like, I'm not going to get in. And I did get in. And if I hadn't applied, or I might have limited a lot of my opportunities. So, and honestly, I probably wasn't as proactive, like scholarships and those type of things. Like, they're out there, you have to search for it. So if you have that dream and that desire, go for it. Don't feel like you can't achieve it. And there's a lot of tools out there. Like, when I was at Duke, like, I went from being, like, in high school, like one of the smartest kids in my class, to when you get to Duke, everyone kind of at your level. And then when you get to med school, it's the same thing. Everyone's at your level, which is a good thing because it pushes you to do more. But there's resources out there. Like, I, for the first time, would go to tutoring and get a little, and it's not because you're behind. I was still doing good in the class, but it's because you want to understand and learn the knowledge. And the funny thing is, your classmates that are doing just as well in the class as you are there in tutoring doing the same thing. So
So don't
it's
be
not
ashamed to
something.
go to tutoring.
It's not like you're doing bad and you're struggling. You're doing well. You just want to keep doing well, and the people that are also doing well are there. So it's something where, like I said, you just gotta kind of don't limit your possibilities by thinking you can't do it. Go for it, because you'll be surprised where you can get yourself.
So don't let doubt and fear stop you. And
Exactly.
then drop your pride and reach out for help. It's okay.
Yeah. Even going back to the fellowship, I honestly almost didn't apply to the fellowship because I doubted myself. I was like, why would I get this position? And I turned in my application last minute because I got a nudge from my wife that I should go for it. And I got it. It was a position only two people could get. And I got one of the positions, but I was that close from almost not getting it because I had doubt in myself. So
Uh, that will always be there. You just got to punch it in the mouth and keep moving forward. Awesome. In closing, how can you be contacted if anyone? Are you on social media where someone can contact you to see you, or
I don't really have a presence on social media. Like, I probably still have my accounts, but I rarely go on there. So, uh, but I don't have like my own like personal practice but I work throughout the valley. I help a bunch of different clinics and facilities out with kind of evaluating their patients and doing procedures.
okay?
So
So can you be found if someone Googles you, Dr. Michael Givens, and they want to maybe see you?
yeah. If you Google me, the clinics that I work at will likely pop up, and you'll see me. So
All right, very good. Thank you. Thank you so much for your time and an effort in this endeavor. Thank you for sharing your knowledge and your expertise. Please stay on. I want to talk to you offline. And again, thank you so much. We really appreciate you, what you're doing. You truly are making an impact out there. Thank you.
thank you. I enjoyed my time.